Hello.
Sir, you are not visible, sir.
Okay. Yeah, just a second.
I'm sharing
Is
my
it okay?
screen. Yes,
Yeah,
sir,
is it
you are
okay?
visible.
Yeah.
Yes,
So
yes.
thank you, Arnav, and thank you, Bear, for the introduction and this opportunity to talk about darolutamide in the sense of treatment of prostate cancer. Uh, so as we can know that in any other cancers we have had a rapid evolution with the introduction of immunotherapies and a lot of research going on. But relatively, prostate cancer has been slow. But we have few very new medicines like darolutamide, which have shown uh, extreme efficacy. We have had the ARASENS trial and the ARANOTE. Now we have the ARANOTE trial, which have been extremely sensitive, efficacious in uh, the treatment of metastatic hormone sensitive prostate cancer. So today I would be talking about breaking barriers in metastatic hormone sensitive prostate cancer using doublets. So we will be talking about usage of darolutamide plus ADT, and we'll be discussing about the aeronaut study. Next slide. So this is a disclosure. So as we can see that this evolution of treatment of prostate cancer, as I told you, it has been a relatively a little slow progression, slow but steady progression, with the standard of care in prostate cancers having evolved to combine ADT with AR inhibitors and abiraterone or docetaxel. So we had in 2014 the charted trial with the combination of docetaxel with ADT. Then we had the Stampede arm C, which was also the combination of docetaxel with ADT, and then we had the Latitude trial that combined abiraterone with ADT, and we had the Stampede arm G with again abiraterone comes into the picture. Then we have the Arches trial, which had combined enzalutamide with ADT, and the Titan trial, which was apalutamide with ADT, and then we have the Enzamet trial in 2019, and finally followed by the Peace one, which is abiraterone with or without docetaxel and ADT, and then we had the latest in the sense of the series of trials on darolutamide, which with combination with ADT and docetaxel, or just with ADT. And so, despite treatment with ERPIs with ADT or docetaxel plus ADT, a large proportion of patients with metastatic HSPCs will progress to metastatic CRPCs within the first 3 years. Next slide. So there is definitely an unmet need for the efficacious treatment, which offers a differentiated and improved safety profile for patients with metastatic HSPCs without adding significant toxicities and with a low drug-drug interaction. So the ARASENS was a phase 3 study in combination with docetaxel that already showed beneficial efficacy in metastatic HSPCs, leading to its approval in India in 2023. Similarly, we had the Aeronaut study in which the darolutamide in combination with ADT would improve the efficacy with a favorable safety profile in metastatic HSPCs patients. It was again a global phase 3 study with significant number of Indian patients. And then we had the Aeronaut data which combined darolutamide with the potential to change the treatment paradigm, as now it would be only ARI which would be used with and without chemotherapy. Next slide. So as we all know that darolutamide with ADT with docetaxel is the standard of care for metastatic HSPCs. And in the ARASEN study, darolutamide plus ADT with docetaxel demonstrated favorable efficacy and safety versus ADT and docetaxel in patient with metastatic HSPCs. So ARANOTE was designed to evaluate darolutamide plus ADT versus ADT to provide a new treatment option for metastatic HSPCs without docetaxel. So we had combination of ADT, darolutamide, and docetaxel, which was having favorable safety versus if darolutamide was not used. And this study, that is the Aeronaut study, was designed to evaluate darolutamide with ADT versus ADT alone. So definitely we are, in all the arms we are trying to test what exactly, if we can remove the docetaxel and achieve similar efficacy, uh, while combining darolutamide with ADT. Next slide, please. So Aeronaut study design was it was a randomized double-blind phase placebo-controlled phase 3 study, and it enrolled approximately 665 patients with metastatic HSPCs with histologically or cytologically confirmed adenocarcinomas of the prostate with ECOG PS 0 to 2, and the stratification factors were visceral metastasis as accessed by central review, and poor prior local therapy. So it was randomized into 2:1 randomization with darolutamide 600 mg BDT with BID with ADT, or placebo alone with ADT. And the primary endpoints were overall survival, time to initiation of subsequent antineoplastic therapy, time to CRPC, time to PSA progression, and rates of undetectable PSAs. So how fast this acted and led to decrement in the PSAs, as well as time to pain progression and safety profile. And other pre-specified endpoints were PFS2, time to SSEs, time to deterioration of FACT-P total, and time to first prostate cancer related invasive procedure. And so 100% crossover to the open label darolutamide was also allowed, and the selected endpoints were overall safety and overall survival and the efficacy. So this data cutoff was in June 2024, and the median follow-up was around 25 months for the 25.3 months for both the groups. Next slide, please. So in both the arms, that is darolutamide with ADT and placebo with ADT arms, we had a pretty balanced population, and we had a significant chunk of patients who were Asian. So approximately one third of the patients in both the arms were Asian. So approximately out of total of 446 patients, we had 144 Asian patients in the darolutamide with ADT arm, and out of the total of 223 patients, we had 65 patients of Asian origin. So in rest of the things, percentage-wise, both the groups were more or less similarly balanced with ECOG PS 1 and 2 in both the arms, and visceral metastasis and prior local therapy in both the arms. Next slide, please. So this was the representation from the we had a significant percentage of patients from India. So we almost approximately 15% of the patients, 15 less than 15, around 12% of the patients were from India, and in both the arms around and 14% of the patients were from India in the uh, ADT only arm. So we had a significant patient population. Next slide, please. And what we saw was that the hazard ratio for RPFS was 0.54, favoring the darolutamide with ADT arm, and the median OS was also the median PFS was also not reached, and there is a wide separation of the curves right at the beginning, right at in months, around 3 months or so. There is a wide separation of the curve, so that means that darolutamide with ADT has got rapid efficacy. So and this median follow-up was 25.3 months in the darolutamide and similar follow months in the placebo, that is placebo with ADT group. So what we can see from here is that there is a significant differences in the response right at the start of the trial. Next slide. And we come across, if you look at the subgroup analysis of RPFS, so we come across that in all the major subgroups, all the subgroups, irrespective of age or baseline PFS values or performance score at baseline or in the initial grade of the tumor or the so basically out of everything, all the tumor related factors or patient related factors, darolutamide arm was significantly better. And mostly it is to be mentioned that even in low volume prostate disease, there is a significant advantage of using the darolutamide with ADT arm. Even in high volume disease, and there all the hazard ratios were favoring the darolutamide with ADT subgroup. Next slide. So yeah, so again, at the time of analysis, OS data was immature in the and in the darolutamide with ADT group. And since OS was immature, patients will be followed up for survival, and all remaining per protocol placebo patients offered to cross over to darolutamide after the primary analysis. So because of the outstanding initial results, and after 25 months of follow-up, there was a very significant one-sided response favoring darolutamide. All the patients were given the option to cross over to the darolutamide, which was allowed in the trial. Next slide, please. So again, the time to CRPC, which was one of the endpoints, secondary endpoints, to look for the efficacy of darolutamide. So darolutamide arm again, even in the starting of third to fourth month, there is a wide separation of the curves, as you can see from the first graph, first survival plot. That darolutamide was with ADT was significantly better with hazard ratio of zero point 0, and in also in the time to pain progression. So darolutamide was better as compared to the ADT alone arm, with wide separation of the curves right at the 6th to 9th month. And again, this was also statistically significant with a hazard ratio of 0.72. So in conclusion, darolutamide with ADT delayed the time to pain progression, and this is of high importance to patients and have not been demonstrated with other AR inhibitors till date. Next slide, please. So again, reaching a PSA less than 0.2, that is undetected PSA levels at any time during the treatment, was also achieved with darolutamide earlier. So again, we can see that time to PSA progression was also wide. Extremely wide gap between the both the arms. So darolutamide was working all here also very quite well. So darolutamide with ADT was the standard of because it was rapidly acting with long time to progression or long duration of biochemical relapse. So 63% of the patients in the darolutamide doublet arm attained PSA less than 0.2, and this represented a 69% improvement in time to PSA progression in the darolutamide arm versus ADT alone arm. So as you can see that hazard ratio of 0.2, 0.3, 0.5, these are not easily expected in clinical trials. But darolutamide combination with ADT has proved that it is quite superior as compared to ADT alone. So darolutamide with ADT achieved deep and durable PSA responses. Next slide, please. So also there was a higher proportion of patients who achieved undetectable PSA. So one thing is that darolutamide achieves undetectable PSA faster. It delays progression related events more than the ADT alone. Plus the duration of PSA which is there is also more. So the duration of low PSA, the maintaining low PSA levels, undetectable PSA levels is also more. And as we can see from this comparison, that even in high and low volume disease, there was a significant proportion of patients with darolutamide and ADT who had benefited with undetectable PSA levels. A significantly high proportion of patients who had achieved undetectable high PSA levels. Next slide, please. So if you look at the subsequent life-prolonging anti-cancer therapy, uh, a higher percentage of patients required subsequent life-prolonging and anti-cancer therapy in the placebo, that is the ADT alone arm, as compared to the darolutamide arm. So patients with subsequent life-prolonging systemic antineoplastic therapy was only 32% required in the darolutamide arm versus 42% in the placebo with ADT arm. Next slide. So incidence of treatment-related adverse events were similar between the treatment groups, and discontinuations were lower in the darolutamide arm. So frequently we say that addition of a drug, leads to more frequent discontinuation, but here it was reversed. So darolutamide has got advantages in addition of darolutamide has got advantages in use in both the sides. So it increases efficacy. It achieves things which are to be achieved faster, and with the achievement is durable, as well as it has got less side effects. So if you look at the darolutamide with ADT arm, so any adverse events was 91% versus 90% in both the arms, which is quite similar. And grade 3 and grade 4 adverse events were also similar. So no extra adverse events related to addition of darolutamide. And there was a very similar treatment related adverse events which led to discontinuation of darolutamide, but it was like lesser in the darolutamide arm. So median treatment duration was 24 months in the darolutamide arm versus 17 months in the placebo arm. And the safety profile of darolutamide in ARANOT was independent of PSA response and consistent with the favorable tolerability first seen in ARAMIS and ARASENS. Next slide, please. So rates of most common adverse events were low and similar between the treatment arms. So as I already told in the previous slide that and despite the addition of a very potent anti-cancer drug to the standard of care ADT, and darolutamide was actually reported to have decreased toxicities, or at the most similar toxicities in both the arms. So and apart from that, the good thing was that darolutamide achieved the efficacious and prolonged control of the PSA to undetectable levels uh, when combined with ADT. So as you can see from these graphs that from this table that in both the arms, that is darolutamide with ADT or placebo with ADT arm, in both the side effects were similar. And only thing is that darolutamide with ADT, fatigue was a little higher, but that is obviously much manageable if rest of the other things are manageable. So fatigue was the only thing which was more in the darolutamide arm, but again it was not very severe to be leading to treatment discontinuation. Next slide, please. So again, if we look at the rates of adverse events commonly associated with ES, which were similar across the treatment arms. So again, we have already discussed this, that the rates of hypertension, vasodilation, diabetes, or cardiac arrhythmias, it was more or less similar in both the arms. And it was nevertheless grade 3 and grade 4 adverse events, or that dose limiting adverse events with darolutamide was much lesser as compared to the placebo arm. Next slide. So in ASCO 2025, this paper was presented, which showed that darolutamide confers a positive impact on you know, health-related quality of life, and darolutamide is the first and only AR inhibitor to demonstrate clinically meaningful delays in pain progression and overall well-being. And this had achieved a hazard ratio of 0.76 with a significant p-value. And darolutamide extended median time of deterioration in FACT-P total score by 5.1 months versus placebo. So next slide. So, and darolutamide doublet therapy demonstrated clinically meaningful delays in deterioration of overall well-being, especially on social, functional, and urinary symptoms. So, as we all know that not only the treatment of darolutamide uh, achieves greater responses, better responses, durable responses, its side effects are also low as compared to ADT alone, and more importantly, it lesser of the patients need second line treatment, and uh, it also leads to better quality of life of the patient because of better cancer control. Next slide, please. So if we want to conclude, we can easily say that darolutamide with ADT significantly improved RPFS in patients with metastatic HSPCs. Darolutamide showed a benefit across all secondary endpoints, which is very, very evident. And darolutamide was associated with a deep PSA response, regardless of deep and durable PSA response, regardless of the baseline PSA. And darolutamide is the first and only ER inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, including social family well-being, functional well-being, and urinary symptoms by better cancer control. And darolutamide had a favorable safety profile. So darolutamide with ADT without docetaxel should become an additional standard of care for metastatic HSPCs. Next slide, please. So with this, I would conclude my talk, and I would be happy to take any questions, if at all.
So as of now, there is no questions. We have also have chat box. If anyone have any questions, you can take and type in chat box as well.
Okay, okay.
So should I move to the next session, sir?
Yes, I think we can go ahead with the next session.
Thank you, sir.
Yeah. Thank you. Thank you.
Pulu madam, are you there?
Yes.
Madam, welcome you. Welcome to today's session. So our next speaker is Dr. Polu Basu. This speaker needs no introduction, but still, Madam is from NCRI, Kolkata, and Madam will present one of her case. So, Madam, do you want me to share the screen?
Yes, kindly share the slide.
Sure, sure.
So first of all, thank you, Buyers team, Arno, for giving me this opportunity. So my talk is on role of darolutamide. It's a real world case. It's a case of non-metastatic CRPC. As Kushalda have already explained the role of darolutamide in prostate cancer. Now it's a real world case where we use darolutamide. Next slide. Next slide. This is my disclaimer. So now coming to patient background. So patient 73 was gentleman, ECOG PS was 1, and patient had a complaint of frequent micturition. Along with that, patient had a left-sided inguinal swelling for last 3 to 4 months. Patient had a history of CABG last 6 months back, and at that time we did a MRI. Next slide. And we did a MRI on October 2018, and it revealed that there was a neoplastic lesion of prostate, which found there was extra prostatic extension. Along with that, there was multiple enlarged lymph node in the pelvic region, along with the left inguinal region. Day 1 PSA was done, and it was 265 mg per dl. So at that time, biopsy was done, which revealed that it was a prostatic adenocarcinoma. Gleason score was 4 plus 3. So metastatic workup was done. PSMA PET CT revealed no mets. So at that time, in view of old age and there was a lots of comorbidity, so patient was on single agent ADT GnRH analog. So patient we initiated leuprolide first, and patient was on only ADT. After that, there was consecutive 3 rise of PSA value. Next slide. So these are the list of medication. As I have already mentioned, that patient already had a history of CABG 6 months back. So these are the drugs patient already is on. Next slide. Next slide. So there was consecutive 3 rise of PSA. PSA was 0.72, and next there was a rise 1.71, and again there was rise after 14 months. There was again a rise of PSA which was 2.4. So we can say that there was consecutive 3 rise of PSA 0.72 to 1.71, 1.71 to 2.4. And PSA doubling time was calculated by PSA doubling time calculator, and it was 9.9 months. Next slide. So at that time, PSMA PET-CT was done to rule out any mets. Next slide. So again, there was no metastatic lesion. There was no bone mets. Again, there was gallium-68 PSMA imaging suggests that there was only primary prostatic malignancy with no regional and distant metastasis. Next slide. So we can say that it's a case of non-metastatic CRPC. See the PSA response. Leuprolide was started from October 2018, and then there was gradual 3 rise of PSA value. So darolutamide was started in September 2022, and just see the response. There was a very good response. Last PSA was done even actually on April 2025, their PSA value was 0.28. So PSA there is a very good control. This particular patient is still on darolutamide, and patient did PSA on January 2026. Again, the PSA value was 0.10. So we can say that is a gentleman where we had a history of CBG, and patients have lost of list of medication. Patients have lots of comorbidity, and it's a case of non-metastatic CRPC. Patient still is on darolutamide with a very good PSA control. Next slide. So now coming to our question that why this particular patient is on darolutamide, we know that we have 3 options for non-metastatic CRPC. We have one option like apalutamide, we have options of enzalutamide, and we have options of darolutamide. So if we compare the efficacy, yes, overall survival benefit was there, but why we choose darolutamide? One is there is least drug-to-drug interaction. So this particular patient already is on lots of medication. So we need to start a drug where which have a least drug-to-drug interaction. If we compare darolutamide versus enzalutamide versus apalutamide, this particular drug, darolutamide, have least drug-to-drug interaction. Second is due to its unique structure and flexibility, there is less CNS penetration. So less CNS side effects is there. If we see the apalutamide, again there is a chance of CNS side effect, CNS side, even sometimes patient present with seizure. And if we talk about enzalutamide, there is a chance of CNS side effect too. So mostly because of these 2 reasons, and in view of very old age history of CABG, darolutamide was used, and this darolutamide has a, we know that each particular drug has a better safety profile, and as I have already mentioned that least drug-to-drug interaction, and this particular patient already had a history of seizure. So that's why we use this particular drug for non-metastatic CRPC. And till now, this patient is on darolutamide, and therapy is well tolerated with a very good PSA control. Next slide. So now coming to our conclusion that we can say that yes, this particular drug has a very better safety profile with lesser drug-to-drug interaction. So it's a safest therapy option in patients with history of seizure. And we have 3 trial data. One is Aramis trial, where they use this darolutamide, and which suggests that patient is on darolutamide have longer duration to progression in bony pain. So quality of life is very important for prostatic cancer patient. So we can see that non-metastatic CRPC, even it means if we have 3 options, we have enzalutamide and apalutamide. We have our Spartan data, we have our Prosper data, but we can say that we can safely use this particular drug because this drug has least drug-to-drug interaction. So I think with this, I conclude my talk. Thank you.
Thank you, madam. Thank you for letting us go through your case. So if anyone have any questions, they can ask. Madam, I don't think there is any question. Thank you so much uh, for the presentation.
Thank you.
So may I ask Dr. Bhushan Gupta sir to please conclude the session, sir?
Yeah, so thank you, Dr. Polavi, for the wonderful case discussion. And so, as we can all conclude from the today's talk, is that darolutamide with ADT is a viable option, and it has got good response rates as well as efficacy and durable, rapid, and sustained PSA control. Apart from that, the response is seen early in all the patients, irrespective of their socioeconomic or fitness or disease profile, irrespective of the disease biology also. So all patient host and related factors, disease related factors. And what we can conclude is that darolutamide with ADT is also very safe for elderly patients, as well as those patients who have got other comorbidities, as we saw in the previous case discussion. So definitely darolutamide with ADT combination has a very high potential, and it should be recommended it is already as a standard of care for metastatic hormone sensitive prostate cancer patients. So with this, I would be happy to take any questions, if at all, if there are from the audience. And after that, we can conclude the session. We would like to thank the organizers, Bayer, and the event organizers for this wonderful weekend session. Over to the organizers.
Thank you, sir. I think there are no questions. So thank you once again for the session, and I think we can conclude the session. With your permission, sir, I'm concluding the session.
Thank you.
I think we can.